It says it's online. Oh no. It says it's bad quality. I hope it's okay. Is it not online? Frick. Output. Stream. YouTube gaming. It should be online. Is it not online? So someone saying someone mentioned something in the live chat if it's online or not. Frick. Oh, it is online. Okay, okay, fantastic. Let me close that. Okay, awesome. But it's like, it's really laggy. Let me close everything that I have open that is not related to my stream. Discord. Close. Oh, my Google Chrome just stopped working. That's fantastic. I was going to close everything in Google Chrome anyway, so that's, you know. And then you're online. Thank you, Molly. You're the best. Okay, sorry about that, guys. The stream always kind of messes up. I hope our internet can handle this, right? It says it's like really laggy, so that's brilliant. Oh, I have to get back to my channels. Okay, let's start. Where's Google Chat? I just need to open up Google Chat, so if you guys have any questions. Once again, I just want to say, if you have questions, just mention it in the Google Chat, the live chat, and I'll answer them for you, okay? Right? And let me know if there's any kind of, anything that happens. Okay. The ping is atrocious, man. Rest in peace, anyone who's playing games with me, like Wendy. All right, so let's start. Week 2, Iron Orbit. So, I'm sorry about the delayed live stream. Last week was your Iron Orbit week, and so I won't go too much into depth, but I do want to clarify or expand upon the stuff that people usually get confused or there's a bit of focus on in the exam. So the number one thing that I'll say from the beginning, and I'll repeat this later and over, is that McMiniman, who I'm assuming teaches you, please correct me if he's not teaching you head and neck, but McMiniman loves eyes. Okay, Professor McMiniman is really, really enthusiastic about eyes, and I like really respect that about him. But what that correlates to is that the exam tends to be really focused on eyes. Like really focused on eyes. Our exam last year was the first exam in quite a while to not really have like an intense focus on eyes. It still had some like not great questions about them. Like some of them involved neuro for some reason, but we didn't get screwed over. But I know, and I know the previous exams have, and I've added some questions to kind of facilitate learning of that kind of focus. Okay, so let's begin. So bony orbit. Once again, I'm assuming you guys have read my notes, so I won't go over the the basic stuff like the base, the superior, the medial, the inferior. Okay, but I will tell you some important parts. Know that with this diagram, the bony kind of cone shaped, like well, not cone shaped, sorry, pyramid shaped orbit is at a 45-degree angle, and that comes into play when with regards to the orbital muscles. Okay, but we'll get to that. Another important thing to note is that you know how I'm assuming people have taught you about the orbital blowout fracture, right? Because everyone's like, yo, ha ha ha, blowout fracture. They keep teaching you about that, right? And I've kind of highlighted that whilst the medial side is the thinnest wall, right? And the inferior wall may be thicker, because the medial wall has multiple air cells, so multiple like cabinets, it's not prone to fractures as much as the below one. So I think the example that Professor McMiniman used was that the medial wall, whilst thinner, has multiple boxes stacked together, whereas the inferior base is basically not thicker, but it's like one big giant box. So any kind of force will push it down into that space, right? And the lateral wall is thicker, and it protects basically the eye against trauma. So if you get king hit on the side, your eye won't be as affected as your pterion. Okay. Your annulus of Zinn. This is also okay. Oh, by the way, common exam question for this might be what does not compose the bony orbit. So just know these colors, and they'll show you what's involved. Annulus of Zinn, or common tendinous ring. So I'm assuming once again you've read this, because this is a bit more specific, but you do need to know what's inside and what's outside, because a common question has been what does not go through the annulus of Zinn. That is a common thing that they've described. The nuances comes with the fact that the first cranial nerve, or the ophthalmic nerve, splits into three branches, right? And they also come into play. So just know this pretty well, okay? Muscles of the eye. This is the one thing that a lot of people got confused over, and I really want to facilitate this learning. Okay, I really want to make sure you come out of this lecture knowing this. And for those of you who know this, I'm sorry, but there's nothing wrong with not knowing. So with this muscle, I'll talk about the 6 main ones. Okay, so the lateral medial rectus, the superior rectus, and inferior rectus, as well as the obliques. The one important thing is that there's an easy exam question, which is like, which of these muscles do not control the eye? It's obviously the levator palpebrae superioris, because that moves, as the name suggests, the palpebra, or the eyelid, not the eye itself. Okay, maybe the question isn't worded as easy as that. It's like, which of these does not attach to the eye? And that's the one that doesn't attach, because obviously it doesn't move the eye. All right. So obviously get used to these movements and what they stand for. So adduction is towards the nose. Intorsion is it rotates towards the nose. So see that med line and have it rotates towards the nose, and extorsion away from the nose. Okay. So let me get some of the animation stuff sorted. Okay. But basically, the easiest muscle to understand, easiest one, is medial and lateral rectus. Okay, the medial rectus moves it to the towards the nose, so abduction, and the lateral rectus away from the nose, so adduction. Also note that the lateral rectus is innervated by cranial nerve 6. Okay, common thing to ask as well. Which of these is not done by cranial nerve 3? Okay, so cranial nerve 6. And which one does cranial nerve 4? It's the SO, superior oblique. I gave the answer. I'm not a good teacher. Frick, man, I'm alone talking to myself, man. That's just you just gotta wonder sometimes, what am I doing in my life? Okay, so I really recommend this video. This video is the one that really clarified how the eyes move, and for me, right, it really kind of helped. So I hope that it helps you as well. But basically, in essence, let me draw some in the flash file as I talk to you guys, right? But in essence, basically, this is where the pyramidal shape of the eyes comes into play, because whilst the lateral and medial rectus are easy, they're like, they abduct and adduct, the obliques and the superior inferior rectus are not as easy. Okay, and the reason for that is the muscles alter their function depending upon the positioning of the eye. Okay, so if the eye is, for example, abducted, it has those 4 muscles have a different function as compared to if they were adducted. Okay, and I'll hopefully explain that, as we kind of progress on. Okay, so firstly, the first muscle I want to kind of I want to do this in terms of positioning. Okay, so if the eye, I put both of them in, but I shouldn't have put both of them in. Okay, the first example I want to do is if the eye is abducted. So if the eye is towards the nose. Okay, think about that. Think about this example. It's the best one I could find. So the eye is now towards the nose. What happens? And look, this image is perfect, because look what happens to these muscles. Okay, so it moves towards the nose, okay, and the superior rectus and inferior rectus are directly in line, like vertically with the eyeball, with the actual what do you call this? The not cornea, the iris and the pupil and the part that actually sees. Okay, so when this muscle contracts, you can imagine this eyeball going upwards. Okay, You can imagine, like, it's easy to imagine that. And similarly, inferior, it will go downwards. So when the eyeball is abducted, the superior and inferior rectus will move this up and down, right? And similarly, because this superior oblique is at a weird angle, right? When it contracts, it won't move it up and down. It won't just move it up and down. When it contracts, it will shift the entire eye towards it. And so the superior oblique, if you like, maybe draw this in the exam, but if it contracts this way, the eyeball will intort, okay? The superior oblique will intort the eye, whereas the inferior oblique, with the similar principle, will extort the eye, okay? This is a fantastic picture that I found, and it really helps with understanding it, okay? Now, adducted, look at this one. So this is an adducted eye. Ah, sorry. Oh no. Oh no, I did an error. Oh frick. I'm sorry. Okay. Oops. Thanks for clarifying, stream. Okay, no, yeah. So, which one's the best abducted? Yeah, I was gonna say, because they're like perfect. Yeah, I know, right? Okay, so, no, here, yeah, this is the better picture. What am I looking at? So this picture is what I was talking about. Sorry. Yeah, so when it abducts, it's looking away from the eye, okay? And now, yeah, I was gonna say, so the superior oblique, as you can clearly see, when it pulls this way, it will have basically no up and down action. It's just like, yo, it's gonna pull it completely to the left and right. Whereas the superior rectus, when it pulls, it will move it up and down. This image is the clearer one. I'm sorry, I pointed at the wrong one. So on abduction, right, superior rectus and inferior rectus will move it up and down, so elevation, depression. Whereas upon abduction, the eye goes away, the intorsion of superior oblique and extorsion of inferior oblique, okay? Sorry, I pointed at the wrong image, but I meant to talk about this one. Okay, so now with the adduction, so towards the nose, okay, with the adduction, now look at this. Now this is like a really, really focused eye. So the previous image wasn't as adducted. So this is a really adducted eye, okay? It could probably be more adducted, but who cares, right? So in this version, it's a bit more confusing. So with the rectus, as you can see, right, it's not directly vertical with the actual visible eye, okay? And so when it contracts, okay, when the superior rectus contracts, it will pull this eye towards this direction, okay? This direction. So by this direction, I mean towards the nose, okay? And therefore intorting the eye. Similarly, the inferior oblique will extort the eye. Now, the confusing part comes in with the superior and inferior obliques. Those two are the more confusing ones because most people assume, hey, look, it's within line. If I contract the superior oblique, okay, if I contract the superior oblique, it will go up because it's superior, and inferior oblique, it will go down, it's inferior. Well, the thing is, they both attach to the posterior of the eye, okay? So imagine a ball, okay? If you attach a rope to the back of it and pull, okay, on the top, like in the top of the basketball, but on the posterior side and pull, it will move the eyeball down, okay? And that's exactly what superior oblique does. And when you pull the superior oblique upon adduction, it will move the eyeball down, okay? It will depress the eye, right? Like this. See, this is the perfect example of it. So this is the normal eye, and when the superior oblique contracts, boom, the eyeball looks down. So superior oblique does depression, whereas the inferior oblique, when it contracts from the bottom, it does suppression, elevation. It does elevation, okay? And I've kind of summarized that here, okay? So with the adducted eye and with the abducted eye, what it is doing. And the part that I highlight is these two because they love examining that because there's a common point of confusion, okay? An easy thing that I remembered was that the superior muscles will always intort and the inferior muscles will always extort. Something that I found was helpful just to clarify things, but just a bit of logic and drawing kind of helped me just remember the entire thing, okay? And you gotta know this H thing, right? Because they'll ask you, they'll be like A, B, C, D, E, F, G, and they'll ask which of these would be the best position to test this muscle, okay? And they'll give you like superior oblique, and you have to know that superior oblique is best utilized, okay, when depression on adduction, right? Because obviously they're not going to care about intorsion, extorsion in this H graph. but they will care about the elevation depression. So you have to know this H graph pretty well. Now, the anatomy of the palpebrae, some of these slides I've only added because McMiniman is addicted to it, Professor McMiniman, and it's worth knowing just to have a kind of fullness, okay? So I'm not going to focus too much into the finer details. However, there are some parts I want to know. No, these are what Professor McMiniman is addicted to. Yes, okay, so the lacrimal gland. I found at the lacrimation, how they taught it, they just kept saying lacrimation as if it made sense just by repeating it over and over. And I had to go out and find the pathway of lacrimation to fully make sense, right? Okay, so basically lacrimation gland. I found this really fascinating. If you guys don't know, I want to be an ophthalmologist, so eyes are my favorite thing, okay? So the lacrimal gland produces fluid on the lateral side of the eye, okay? It produces fluid on the lateral side, and that's why the human eye, when you blink, it's really quick, but slow-mo blinking shows that it's not complete up and down. It actually closes from lateral to medial. So your eyelid goes like lateral, 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 medial, and it closes like that to kind of spread out that lacrimal fluid all around the eye, okay? Once it reaches the medial side upon blinking, it gets sucked in basically like a vacuum by the lacrimal punctum, okay, which are on lacrimal papilla. Papilla are just elevations, right? So lacrimal punctum are the one that's actually the holes on the elevation that's sucking in like a vacuum. I'm sure all of you have like kind of experiences when you're about to cry, and when you force yourself not to cry, and suddenly the fluid disappears, and it's like, oh shite, where did it go, right? And so the fluid goes through the inferior and superior lacrimal canaliculi, or canals, as you know from like renal and stuff, right? Collects in the lacrimal sac or which is also known as like a lake of tears, or lacus lacrimalis, which is what Professor McMiniman loves calling it, goes all the way down and drains into the nose, okay, via the nasal lacrimal duct. And not the important thing, but it's just the fascinating thing is that when you try not to cry, this is why you get runny nose when you cry, or when you're not to cry. You just get a runny nose because you're not absorbing, you're kind of sucking up all the excess lacrimal fluid. Okay, anatomy of the eyeball. Very important. Testable in a questionable way. Not like, I don't think this part's testable, but this is just like the important part. So the outside is fibrous layer, vascular layer in the middle, and inner layer, the most inner, is the retina. Okay, that's like the most simple part of it. Now the fibrous layer of the eyeball. This part I think is more important than just the basics. And I'm assuming you've read it because I'm not going to go through over all of it. However, what I will go through is that the fibrous layer, the outside of the eyeball, is an incredibly sensitive part. If you grab your finger and touch your physical eyeball, you will blink, you will water, you'll basically have a visceral reaction to it. I hope this stream is still going on. Simon, I know, I did, right? Thanks, Simon. So it's like a visceral reaction to it because there's a heavily sensitive innervation via ophthalmic nerve, or CNV1. But it's easy to get confused with all the general sensation. So this is just general sensation, okay? The CNV1 obviously isn't responsible for vision. It's only responsible for the general touch, okay? And you can test this in a clinical examination via the cotton bud on your cornea, right? And this is like a corneal reflex. And this is related because it has such sensitive innervation that because when it gets damaged, right, the cornea gets damaged all the time. Because think about it, stuff gets into your eye, dust gets into your eye, and your cornea isn't the thickest of things, like me. But once it gets damaged, it gets it heals super quickly because your body's like, yo, it's damaged, heal it up. Another important thing to note is the drainage of these fluid, but I'll get to that. And my favorite thing is going to come up, which is the canal of Schlemm. Okay, so basically the iridocorneal junction, the corneal scleral junction, is the point where the cornea obviously transitions into the sclera. But this marks also the iridocorneal angle. So cornea and iris over here, this is the angle over here, okay? And the reason that's important is because it contains the trabecular meshwork, this thing over here, which is what drains the aqueous humor. Okay, so the aqueous humor is created by the ciliary body over here, goes out from the posterior chamber, right? Goes all the way through the I forgot what this is called, but basically goes through the front of the lens into the anterior chamber and gets drained out by the trabecular meshwork and canal of Schlemm. Okay, and the canal of Schlemm drains it back into the epivascular blood vessels, and it keeps repeating the cycle, right, to make sure there's a consistent flow. And as you guys may see that I'm preluding to, this is what is important for glaucoma. Okay, now corneal histology, this is just something you go to rote learn. They really tried to make us scared by saying this was going to come up in the exam. It didn't. So I felt really bummed out. I spent all that time learning about it and it just didn't come out. So I think it might come out for you guys. Right. What's important about this? Zonular fibers, that's what it's called. Okay, the important part, I think, to know about this is the kind of paradoxical contraction of the ciliary muscle. Okay, so you would think, how do I phrase this, right? You would think that the ciliary muscle. No, hold on. Where am I going with this? Actually, I'll mention this later on, so I'll mention it there. Okay, cool. Okay, so the iris. Okay, no, I'll mention it now. Never mind. Sorry, I changed my mind. So iris and ciliary body. They don't have the most clear of function. Okay, so the most important part I want you to figure out for the iris is what the parasympathetic and sympathetic does. And I hope, I really hope that after 2 years you know that a parasympathetic stimulation will cause you to have contracted eyes, whereas a sympathetic stimulation causes you to have dilated eyes. Okay, think about it, right? You see a tiger, you're scared, your sympathetic activates, your eye wants to see as many things as it can to absorb as much light, except maybe not now with the solar eclipse, you'll die. Well, you'll go blind. And so your sympathetic stimulation activates, your iris dilates via the dilator papillae and opens up. Okay? And it does that because it does. So it does that by kind of contracting away from the center of the eye. Whereas the parasympathetic, it doesn't contract into the center of the eye, it contracts radially like a circle. But basically, yeah, just know what the sympathetic and parasympathetic, because there's a common point of confusion when it comes to CN3 blockage as well as certain medication like belladonna poisoning. Okay, and ciliary muscle, we'll talk about the lens later, I think. Yes, we'll talk about the lens, so I'll mention it then. Okay, so the inner layer of the eyeball, what's important here, basically just everything you've already know, that the macula is the most sensitive part, or sorry, not the macula. Yeah, the macula is the most specialized photoreceptor place, right? It's the one that has the most acute vision. Just remember that. I think that was one of the true or false questions that we got. And obviously this is the optic disc. Ooh, is there anything too important here? Nothing too important. Obviously, also retinal histology. This was something we also had to rote learn as well. I'm sorry, you just gotta fucking go for it. Okay, let's see if you guys have questions. I'm sorry, I'm not. I should be checking any questions more. Just message me if you guys want a question. If you guys have any questions. Okay, so, God, I hate doing it alone. Fracture media, great fracture cornea. No, okay, right. Anterior and posterior chambers. This is what it's talking about. So, you've got to realize that the drainage systems that I mentioned before, where the ciliary body is making in the posterior chamber, going to the front and getting it drained by the trabecular meshwork, is really important because that's how it basically maintains the intraocular pressure. Okay, if it's like I'll get to the conditions later, but it's really important, right, to maintain the pressure with the CSF. Now the lens. Okay, we'll get to the lens. Now, unlike the other structures, perhaps it's avascular. Okay, so the aqueous humor and ciliary body with all the fluid production, that's what basically goes into the lens and produces it. Because remember, the lens has to be clear for it to refract, so it can't have blood vessels within it obstructing your view. All right, And think of the lens as like a balloon, okay? It always wants to be round, okay? Your lens is, I know it's shaped like this, and I'm not sure if you've done dissection, but you should have. But the lens always want to be round, okay? And so the ciliary muscles with these suspensory ligaments, they don't want to do that because obviously they want to control the level of convexity to make sure your vision is like accommodating properly, okay? Now, I think this is the next frame actually. Yeah, this one's better. Okay, so your ciliary muscles, okay? When it relaxes, so when it's not contracting, as you can imagine, these fibers kind of loosen up, and your lens is natural, like your lens is, what am I saying? Wait, what am I saying? No. Sorry, I forgot about this. No, it's the opposite. It's paradoxical. I fell for the trap, guys. Don't fall for the trap. Okay, no, yeah, sorry. So your ciliary muscle, I know in all these pictures it seems like two bands. That's what confused me before. It seemed like two bands to me, right? And I was like, I don't understand this. And then when I saw like a 3D image of these muscles, that's when I fully understood. So your ciliary muscle is like a ring. It's not a band. It's not two bands on top of your eyes. It's like a ring, okay? So when your muscular ring relaxes, so it's not contracting, okay? It basically it forces these ligaments, which are like basically I thought of it as a set length. Because it's relaxing, this ring is now further apart and therefore stretches out your lens. Okay, it stretches out your lens. So instead of what I just thought, so most people think that when the muscles contract, this also squishes because it makes sense, right? But this is the opposite. When these muscles relax, it stretches out. It's stretching out this lens. Whereas the parasympathetic, okay, or the constriction of this ciliary muscle brings these ligaments closer, and your lens' natural tendency to become fat and a ball, makes it stretch out, and therefore allows you to have greater vision in a short-sighted situation. So it's a paradoxical thing. I really want you to understand this because, as you just saw, I obviously forgot it after a year of not revising this. Okay. Now we get into the cranial nerve pathways. Okay, and I think the most important one is cranial nerve 2. Oh, Jesus! I should not have put this much text into this one. Okay, let's not move. Okay, let's not skip ahead. Now, the optic nerve, it's obviously the special sensation of your eyes. So unlike CNV1, which is general sensation, this is the specialized sensation for your eyes. And along with CN1, it's attached directly with, it doesn't join with the brainstem. It's almost like an extension of the brain, right? So it's surrounded by the cranial meninges as well as CSF within it. Okay. With the pathway, the only important thing you need to know is that it forms the optic chiasm above the cavernous sinus and near the pituitary gland. Also, obviously, if you have a pituitary adenoma, it will impinge upon your vision and give you, buzzword, bitemporal hemianopia. Okay? Now, with this, I don't think this is super, super important, and I'm not going to get into the physiology, I don't think. I don't want to get into the physiology of it, but know well the kind of split of your eye fields, okay? Like, for example, if a patient presents with their left eye's left half, your left eye's left half missing, which part is affected, okay? Know that well, because they love testing that. The only confusion becomes, and I don't think they'll be dickish enough to do this, but they might, is when they break it up into quadrants, okay? When they break it up into quadrants, then it gets a bit more confusing, because similar to how this works, how your visual field up here is directly on the opposite side on your retina, the same thing happens with your quadrants. So, for example, this yellow part over here, and this diagram is fantastic in my opinion. This yellow thing is on the retina, is on the opposite side and the opposite location. So it's directly opposite, okay? And that translates over to where it's going as well, okay? And I've kind of detailed this, but it's not red, okay? Just read it in your own time. The mnemonic, I think, over here is pi in the sky. I didn't write this, but pi in the sky. So it's parietal inferior, okay? Parietal's inferior because it is in charge of the inferior visual quadrants. So over here, over here. These two is done by the pi or parietal lobe, okay? And the sky, TS, PITS, pi in the sky, is temporal lobe, is important. It's important for the superior visual fields. So these two up here, okay? Pi in the sky, pi in the sky, okay? There you go. Oculomotor nerve 3. Okay. How much do I have left? Oh, not much. Okay, so cool. I think I can spend time on this, hopefully. Okay, so as you know, nerves 3, 7, 9, and 10 are the ones that have autonomic supply. Okay, cranial nerve 3, 9, 7, 10. 3, 9, 3, 7, 9, 10. Wow, what order did I go in? Okay, so, but you also know that cranial nerve 3 is responsible for all the eye muscles except superior oblique lateral rectus. Okay, now, an important point to note is that the oculomotor nerve 3 only has parasympathetic fibers. However, sympathetic fibers do run with the nerve. Okay, so initially, although it comes with parasympathetic, sympathetic comes in and attaches to it. Okay, so I just want you to follow me through this magical adventure of oculomotor nerve 3. Okay, so it comes out your brain, enters cavernous sinus. Okay. Now, when it reaches the sinus, when it goes through the sinus, because I'm sure you know what goes through the sinus now, it basically receives sympathetic branches from the internal carotid plexus, which is that sympathetic plexuses. No, what's the plural? Sympathetic plexi? The sympathetic plexus has formed and traveled with the internal carotid artery, went all the way up, and there's branches which gives it to the brain, because I'm sure you guys remember that the sympathetic is a what's the correct term? Thoracolumbar. It's not in the craniosacral. So the common question was, how did the sympathetics get into the brain? Well, it didn't, right? It still remained in thoracolumbar, but then jumped onto the internal carotid and traveled all the way up. Okay, it's freaking sus like that, right? It leaves to the superior orbital fissure, which is important to know, and divides into inferior and superior branches. Okay, so obviously the superior goes into the superior most superior to, so superior rectus or levator, and inferior branches goes to like almost everything else, right? Now, sympathetic and parasympathetic. This is where all the information comes from. Okay, so now where did the autonomic supply go to? And in my previous live stream, I mentioned almost 3 ganglions in one go, but not the ciliary. I don't think I talked about the ciliary. So this is now where we talk about the ciliary ganglion. Now, the sympathetic and parasympathetic from cranial nerve 3 forms a ciliary ganglion. Well, no, joins the ciliary ganglion, right? And it forms a short ciliary nerve. So in this diagram, this one over here, right? So think about it. The sympathetic comes in, right? The the parasympathetic of cranial nerve 3 leaves it and joins this as well. So this is the red one and the blue one over here, okay? It forms a short ciliary nerve, okay? The short ciliary nerve goes in and supplies the blood vessels as well as the sphincter pupillae and ciliary muscles. So this is where so the sympathetic basically supplies the blood vessels. The important part of this short ciliary nerve is only the parasympathetic, not the only, but this parasympathetic, which gives it to the muscle and the muscles, sphincter pupillae, and the ciliary muscles. But then I'm sure you're thinking, but Maz, if the short ciliary nerve sympathetic only gives it to the blood vessels, and the parasympathetic muscle gives it to the muscle, where did the sympathetic fibers for the muscles go, right? Because I've only told you that the parasympathetics have been supplied. So where did the sympathetic go? Okay, so the thing is, the internal carotid plexus, whilst it does give sympathetic to this ganglion, it also bypasses that ganglion, okay, by giving some sympathetic fibers to nasociliary nerve from the ophthalmic nerve. Okay, so CNV1, you know how it has 3 branches, frontal, lacrimal, and nasociliary? It kind of it becomes a sneaky little bitch and gives sympathetic fibers to that. And because that doesn't go through the ciliary ganglion, it just goes like, phew, it goes straight to the eye, which is also called the long ciliary nerve, and that's why it's called long, because it doesn't go through the ganglion, and that's what supplies the sympathetic for the superior tarsal and dilator pupillae. Now, and you're asking why the nasociliary nerve? Because remember, the general sensation of the eye is done by the 5th cranial nerve, and that's how it's done. So the short ciliary does the parasympathetic, the long ciliary does the sympathetic and the general sensation. I just found that like explaining it all in one go is more important. Like it really cleared things up instead of what Monash likes to do and just gives you like little bits and pieces and tells you to basically F off and learn everything, right? Another important thing, and that I added this after the exam because I think it was examined, is that with the order of cranial nerve 3, right? The parasympathetic fibers in the cranial nerve 3 is on the outside of the fiber. So if you imagine a tube, actually let me switch over to my animation thing here. Okay, so if you think, forgive me for the orbit and screw the orbit. I don't like you anymore. So if you think about the cranial nerve as a little like circle, right? God, why can I not make a circle? Okay, there you go. The motor fibers are on the inside. So this is cranial nerve 3. The motor fibers are on the inside. So this is, I'm gonna color it blue, motor. Okay, and on the outside is the para. Wow, my writing is just awful. Para. I hope you guys know what parasympathetic means. Okay, so it's parasympathetic over there. And the reason I mentioned it is the vasculature. The vasculature I should not have used red for that. Oh god, I'm gonna recolor that green now. I'm gonna recolor parasympathetic green. That is way too much effort. I'm not gonna do that anymore. I lied. Okay, so I hate my life. There you go. It didn't work. Okay, so parasympathetic is that. So you know what? I'm gonna do the arteries yellow because that makes sense. No, you might get confused with the nerves. I'm gonna do it green. All right, so it's lymph. So vasculature goes outside in. So it goes whoop. You know, hey, there's vasculature. I'm gonna give you blood, bro. That's not weird at all. I'm swear this is what family does. Okay, so it's giving vasculature from the outside in. Okay, so as you can imagine, the motor component, because it's like thicker, thin, end artery, it's better perfusion here. Better perfused here. Okay, so it's like the outside of the cranial nerve 3 that has better perfusion than the inside. Okay, so if something goes wrong with the vasculature, the motor component, which is worse perfused, okay, will cause it to kind of have symptoms first, then parasympathetic, right? So what I mean is because there's better perfusion on the outside to inside because of how the vasculature is. If something goes wrong with your vasculature, patients will experience cranial nerve 3 motor symptoms first, and then they will talk about parasympathetic symptoms. Okay, so in a patient which comes in with acute cranial nerve 3 lesion, even though they may not have parasympathetic, they might develop parasympathetic symptoms. Okay, they may not present directly with it. Just important thing to know. Trochlear nerve, really small, nothing too important really, just goes through the cranial nerve sinus, gives the superior oblique. Same thing with abducens nerve, goes through cavernous sinus, gives it to lateral rectus. Nothing too hard. Now we get into the meat. These are all like very examinable stuff. Okay, so let's talk about this in the last 10-ish minutes. There's only 2 people watching? Oh no. It says there's only 2 people watching. Well, that's a real confidence booster. All right. Unless it's like really buggy, then I'm sorry. I'm not even recording this on my computer, so frick. Okay, so I'm just gonna keep going. Nah, this is risky. Okay, so cavernous sinus. Why do I kept mentioning cavernous sinus last time and this time, but why is it important? Okay, so as you guys know already, it's a durovenous sinus within your brain. Okay, which is also near your pituitary gland or sella turcica, right? The important thing you need to know is how basically what goes through and where it is. So there was one time in the exam where they were told to draw the cavernous sinus and what goes through it, or basically label it. Be prepared to label it, okay? So remember that the cranial nerve 3, it usually goes in order, 3, 4, 5, 6, okay? From superior to inferior, and then medial for 6. Okay, but also remember the cranial nerve 5 has 2 branches that goes through cavernous sinus. So 3, 4, 5, 1, 5, 2, 6. And the important part you need to know is that the abducens nerve, or the 6th cranial nerve, is medial and right next to the internal carotid. So if there's an internal carotid aneurysm, or if there's something that goes on with the internal carotid, the intercarotid one that goes through this cavernous sinus, you will have abducens nerve pathology first, and then if it gets worse, then it will start to occlude the rest, and then you'll have every other pathology. Okay, but initially patients will present with abducens nerve pathology. Now, so I also wondered when I saw like diagrams like this, is that why is there 2 internal carotid arteries? Well, there's not, right? There's not. What it is that it goes through the cavernous sinus, loops superiorly, goes backwards. So that's what it's doing. It's going like inside there, looping around, goes back up there, and that's why it shows twice. Okay, that's why I got confused. Now, this once again buzzword, but basically, if you have a pituitary adenoma, I'm going to talk about this first. Compression of the optic chiasm, and it basically impinges upon this. So the cranial nerve 2 is optic chiasm, and the optic chiasm is where basically, and now it's time to talk about this, is where your medial side of your retina cross over. And so because that's the medial side of your retina is being impinged, the lateral side of your visual fields will now be non-apparent. Will not appear, and therefore that's what causes this kind of classic pathology. If it's really bad, it'll impinge upon the entirety of cavernous sinus, so you'll lose 3, 4, 6, and sensory of 1 and 2. So they won't be able to feel the forehead, they won't be able to move their eyes at all, etc. Okay, and they'll probably have a sympathetic eye because parasympathetic has been blocked. Okay. Oh yeah, that's another important thing that I forgot to mention here. Because think about it, because the sympathetic of the eyeball is not provided by cranial nerve 3, and it's provided by basically a separate long pathway. When you get cranial nerve 3 impingement, you will lose the parasympathetic supply, but the sympathetic supply will still occur, and so you'll have patients with a dilated eye. It's important. It'll come back up. Okay, orbital blowout fracture. Once again, when you punch the eyeball, the bottom of the floor basically breaks, and increased pressure of the orbit creates a fracture that basically blows inferiorly because of the singular sinus, and basically it makes kind of like a trap door where it traps the muscle and the connective tissue through the fracture, and you're basically physically unable to look up. So in this patient, he's normal in his right eye, and he's trying to look up, but because it's physically trapped by the fracture, this eye cannot look up. And you can see the bruising around the eye as well. Oh, sorry, I forgot to talk about this as well. No, I talk about this. Okay, cool. Corneal problems. Now, you guys might be thinking like, hey, Maz, why so many corneal problems? What are you doing, mate? But the thing is, when Professor McMenamin gets a handle on the exam and he's able to do whatever, he loves asking about pathologies. And even though you're not specifically told all this, he has literally asked some years this. So just know it. The important one you need to know is obviously astigmatism. That's easy. It's just basically you don't have a completely spherical eye. You have like a quite deformity. It's pretty common actually. Keratoconus, by the name suggests, makes a cone. Trachoma infection. The two important ones is very, very common. I think most majority of Western, not majority, but quite a large proportion of the Western civilization have it, is myopia and hyperopia, or hypermetropia. It's basically nearsightedness because of just overuse of short-sightedness, or like gaming and stuff like that, sometimes genetic. And hyperopia is just long-sightedness due to refractive error, so your lens don't work. So myopia, basically you're nearsighted, hyperopia, you're short-sighted. It's different from what I'm going to talk about now, which is presbyopia. Presbyopia, it's used interchangeably, but presbyopia is more a lens problem because you lose the elasticity of the eye when it comes to aging, and so once again your lens tends to focus more behind the eye, and therefore you need a more correction. So that's why old people all get presbyopia, and they're all long-sighted deficient. Cataract is important as well. It's in the opacification of the lens. So the cataract is pretty common in an exam. So like if they show you this picture and you see it like opacification, what are you gonna say? It's cataracts. Okay, easy. Aqueous humor problems. These are pretty. Glaucoma definitely is really important. Okay, so you need to know about this. So once again, I mentioned before, the eye creates aqueous fluid to maintain pressure, right? So if there is a deficiency in that kind of in a mechanism, it will cause your eye to build up with pressure, like this, and produce some pretty classical symptoms. Okay. It'll basically look like the eye is larger, right? Like this ophthalmos in a kind of baby. The increased pressure kind of pushes upon the eye, makes it huge. Okay, it's uncommon, but I just want to mention that. But the more common symptom is basically that it impinges upon your optic nerve. Okay, and the pressure kind of impinges upon the nerve, and you get a loss of peripheral vision, or scotoma. Scotoma. He loves that word, so learn it well. Now there once again I mentioned two things. One, the aqueous humor produces well, and it drains well. So as you can imagine, there's a few pathologies that can go wrong. One is that it is producing too much. Okay, and so that is what open angle. No, sorry. Most of it absorption. Yeah, that's it. Okay, so the open angle glaucoma is this one over here. Okay, and this occurs when there is a kind of inability to absorb all the aqueous humor. So the ciliary body keeps producing as normal, right? And it goes through, but it's not absorbing as normal. So you get a buildup of pressure, and therefore it's an open angle glaucoma. And the open angle refers to the iris and lens. Or as a close angle glaucoma is when there's an anterior displacement of the lens. So there's normal absorption, there's normal production, but there's physical obstruction to this, and therefore is unable to absorb any fluid because everything's blocked, right? And the danger, this is a buzzword and medical emergency, guys. Close angle glaucoma is an emergency. Patients present basically with like inability to see, but also like inability to see, and they go to the optometrist, and the optometrist is like, hey, patient, something's wrong with their eye. And as per standard protocol, what they'll do is they'll put dilator drops in the eye to see what's wrong. If you do that in a close angle glaucoma, you may as well be making them blind. Because if you look in this diagram, you'll notice the iris is blocking the entire thing. So if you dilate the eye, the iris will contract and it further obstruct that kind of pathway, and you're almost surefire giving, and that medication, it's hard to reverse. You really need to like work hard to reverse it. Like give them like all these freaking parasympathetic medication, right? So that's why you've really got to be careful when giving dilators to someone you think has glaucoma. There's a test you can do called the shadow test, which I've learned this year. I don't think it's important, but for your interest, it's you can Google it if you want. Iris and retina, I think all of these are not too important. Papillary edema, he really loves this one. It's basically when there's increased CSF, so from the back of your eye, increased CSF causing the optic disc to push forward, and that's basically it. Pushes forward. Yeah. Diabetic retinopathy, cotton wool spot is the buzzword, cotton wool spot, and optic neuritis is also a buzzword for MS. Cotton wool spot, diabetic retinopathy, optic neuritis, demyelination. Oh, I missed one. Yeah, this is really, really well taught in neuroanatomy, right? In neuro. Yeah, and I think like if you understand it well, you can look at it now. But the really buzzwordy stuff that they'll test in the exam is back here, which I'll explain just now in case it comes in the exam. Look in the middle, like if you have a stroke in the back of your brain, which is where it all begins, you'll realize the middle is okay. Your middle, like the macula, is okay, and it's like, oh, why is there macula sparing? It's because your back of your brain has a dual supply, and so if one of them gets got, or is perhaps obstructed, or in a stroke patient, or like bleeds out or whatever, the other supply takes care of the macula, right? Quadrants once again relates to the parietal or temporal. The lateral fields depend. Basically, learn the lesions and learn where it is, and it's good for you to work out. what does what. Okay, these ones are the most important. No, most important, the most interesting. Okay, cranial nerve palsy 3. Buzzword, 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 down and out. Down and out appearance. If a patient comes in with a down and out appearance, they have a cranial nerve 3 palsy. Now, tell me why. If you can logic it out, you've done well. Okay. Number one thing they should have, as I mentioned previously, is because the cranial nerve 3 has parasympathetic, and because that's gone, patients will not be able to experience parasympathetic symptoms. Their sympathetic symptoms will overactivate because it's not in the cranial nerve 3, and therefore their eyes will dilate. The sympathetic is okay, the eyes will dilate. Okay, so if the eye is dilated, boom, perfect. Down and out. Why would it be down and out? Because every other muscle except for the superior oblique and the lateral rectus is gone. Okay, so if the medial rectus is gone, obviously your lateral rectus will move it to the lateral side. It will move it out. Okay, out. And because once again, now we go back into the muscle movement. If you have an abducted eye, what does your superior oblique do? It does it intorts, okay, but it's like a trick. It's a trick thing. But because literally every other muscle doesn't work, your superior oblique depresses the eye simply because there's no opposition whatsoever. Okay, so abduction of the eye causes down and out. Right, perfect. Now, they'll also experience ptosis because of the fact that, remember, cranial nerve 3 also gives sympathetic supply within that short ciliary nerve, which is, to the superior palpebra. The levator palpebra superioris, and they'll have ptosis or droopy eye, but also dilation. Okay. Trochlear nerve palsy. Now this is also important. So someone brilliant, I won't mention their name, but someone brilliant asked me, Maz. What did they ask me? Oh yeah, so sorry, I was looking at the questions if you guys had asked them any. No, so someone brilliant asked me, hey Maz, trochlear nerve arises from the opposite side of the brain, decussates, and then supplies the opposite side of the brain. And it's like, that's true, it does. Okay, so your left eye, your left superior oblique is innervated by a trochlear nerve that originated from the left side. So originates from the left, goes to your right eye. Okay, and that's true. And then they mentioned, so Maz, if there's a palsy within the cranial nerve 4, will it affect the contralateral side? And my answer was yes and no. Okay, it depends. Because as I mentioned in the last live stream, everything depends upon the point of lesion. So, for example, if your lesion is on at the very beginning, so you have a stroke or something, and it affects the very beginning of when it arises, then yes, your contralateral eye will be affected. However, if it has already decussated, if it's about to get into your eye, and then that's where the lesion is, then your ipsilateral eye will be affected. Okay, it makes sense, right? It makes sense if you think about it. Before it's gone to the opposite side, if you cut it, it obviously doesn't work on the opposite side. If it's gone to the side it needs to, and then you cut it, it won't affect the side that you need to. It makes sense. And get used to that kind of way of thinking, because that's basically all of neuro in a nutshell. So, buzzwords. Okay, but the thing is, in the exam, and I told her in the... confidentiality. I told them in the exam that... they'll give you very, very clear indication. They'll say that specific eye, or the patient looks away the specific way. Okay, so the superior oblique is what's missing with cranial nerve 4. Superior oblique, basically important for intorsion and elevation of your eye in certain movements. Okay, which movements? It directly affects elevation. When it goes to abduction. When you abduct your eye, it does elevation, right? Abduct your eye, it does elevation. So, when you... inframedially. Wait a minute. I'm stupid. Sorry. It's not superior. I was thinking about superior rectus for some reason. I was gonna say superior rectus is fine. Okay, so no, loss of superior oblique, it does intorsion and depression. I apologize. So because they're unable to intort and depress, they can't look inframedially. Think about it, okay? You adduct the eye, you bring it towards your nose, okay? And at that point, if your superior oblique acts, it's meant to look down, right? It's meant to depress your eye. However, because your superior oblique doesn't work, it can't do that. So in this patient, what's wrong with this patient? Which eye is affected? Okay, let me know. If you guys can think about that and answer, that's perfect. Okay. In this patient, their left eye is missing. It's gone. Not missing. It's gone. It's not gone either. It's affected. Their left eye is affected. This eye over here, and you might be asking Mars why. Okay, so he's been asked, or she, I don't actually know. So they've been asked to look towards their nose of the affected eye. Okay, so they've looked towards the nose, but because at that point now the only two muscles work in the elevation and depression, which is the obliques, but because the superior oblique doesn't work, their inferior oblique is now basically overactivating now because there's no opposition and has elevated the eye already. So when you get the patients to look towards the nose of the affected side, the affected eye to look towards the nose, it will look up because your superior oblique doesn't work. Similarly, because intorsion has been affected, what patients will do is that they will actually lean their head. If you think about it, okay, I'm gonna get back into my animation. Sorry, I should also mention the pictures as well. Okay, so have I not been showing you all the pictures? Oh no, that's my fault. I apologize. I'll show you the pictures quickly. Learn this picture. Learn how to label it. Affect aortocranial nerve 6 first. Everything else later. Bitemporal hemianopia, fantastic. This patient over here, you can notice the bruising around it because of the orbital blowout fracture and inability to look up. Okay. All these pictures for all these conditions. I apologize. You can look, as you're listening, you can look through your own slides. Sorry, completely my fault for not switching over. I didn't even get any comments upon it. Yeah, Broth, I'm so sorry. You're right, Broth Godo. I should have definitely switched over. You're right. I was still on my sketches. So this is the closed angle glaucoma. Once again, I mentioned the iris. If it contracts, it will block the drainage further. It will block the drainage even more, therefore impinging upon your drainage system and will cause further symptoms. And it's a medical emergency. The increased pressure because of papilloedema, cotton ball spots because obviously that's the diabetic retinopathy. All these positions are important, so macular sparing, everything is important. Just look at the slides as you listen back to my lecture. These would have been so important as I explained it. Down and out appearance, so the affected eye looks down and out and is dilated because that's what cranial nerve 3 does. Okay, now we're back onto this. Okay, so this patient has been asked to look towards their nose of the affected side, looks up because your depression doesn't work. Now, why does the patient tilt their head? The patient tilts their head because, think about it, unlike the cranial nerve 3, which affects every muscle except 2, this only affects one muscle. And if you're not abducting your eye, the superior oblique isn't really activated either. However, it does affect your intorsion as well. So what this patient will do, the same patient, what they'll do is that they'll lean their head away from the palsy. So remember that his left eye, or their left eye, is affected, but they'll lean their head away because if you think about it, and I'm gonna once again remind me if something goes wrong, but I'm gonna switch back into my sketches. Okay, I'm gonna switch back because what happens is, okay, so this is my person. Okay, I'm gonna draw eyes. This is my person. Okay, and this is their eye. You would assume that if I switched, and now remember the cranial nerve palsy, cranial nerve 4 palsy, inability to look that way. Okay, I can't do that. I'll quickly wrap up. Okay, inability to look that way. So when they tilt their head to intort, so when they tilt their head away from the affected side, what is happening? I love my diagrams. and they're trying to look at the same. They're trying to look at their world in the same way. You'll realize that now this eye now basically never needs to intort, because it's now basically extorting to maintain normal vision. Okay, it's so if they, for example, shifted their head the opposite way, they won't have normal eyes, they won't have a normal vision, they'll have diplopia, because this eye, whilst can extort and maintain the same thing, this one cannot intort, and so it'll have a diplopic vision. Okay, and so that's why they basically tilt their head from the opposite side. I'll quickly run through the rest of it. Abducens nerve palsy, you lose your lateral rectus, very easy to understand. You can't look laterally, and so everything goes medial. Okay, everything goes medially, and if you ask them to abduct this eye, they basically can't abduct past the midline. Okay. Basically, the summary, clinical examinations, you can do it for yourself. Embryology I'll cover in later time, but unfortunately it's also an incredibly higher yield subject. Okay, I think that should be it. Thank you so much for coming. I'm so sorry there was some technical stuff with my stream. Completely my fault. I forgot to switch back. Definitely drop the ball there. If you're gonna listen back, just prepare with your slides, and you obviously know when I switch it to a new slide, because that's when I go which is my tick when learning or explaining things. Okay, all right, thank you so much for coming. All right, laters guys.